items, if I can remind everybody to sign in at the back of the room, as well as enter on their phones the event ID, which the number you want to call is 423-200-3259, and the event ID is 43011. This is different for people who may be watching it remotely, but for this site, this is the event ID. And also at the end of the session, please turn in your evaluations because this is critical for us to be able to continue the CME program. I'm Dr. Jaishankar, Gayatri Jaishankar. I'm one of the general pediatricians from ETSU Pediatrics, and it's my great pleasure to introduce to you Dr. Nilesh Dankhara. Dr. Dankhara came to us in 2012 after doing his medical schooling at CU Shah Medical College in India, following which he worked in Brookdale Hospital as a research intern and had some observerships in the country. Since being here, Dr. Dankhara has done an amazing job, has been very, very involved in various aspects of the residency program, including being prolific in writing abstracts, case reports, and being part of the Read and Play team, which is the AAP grant that is being done through the Department of Pediatrics. Dr. Dankhara, once he finishes in July 2015, plans to practice primary care in South Carolina, and it is indeed exciting that we can listen to him talk about sickle cell disease for the primary care physician. I think a very important topic for all of us, and I am looking forward to his presentation. Dr. Dankhara.
Thank you, Dr. Jaishankar. Thank you. So, my presentation is very long. I did not realize before I started kind of preparing that this topic is this long, so I'll keep going. So, I do not have any financial interest, or I'm not going to present anything that is unapproved or under investigation. So, today's talk, my objective would be definition, pathophysiology, and genetics. So, we'll not go in all the details about that. We'll talk 2 slides about the interpretation of the newborn screening for hemoglobinopathies. We'll talk in detail about the health maintenance part as well as the complication and treatment option and prognosis and survival in short. So what is sickle cell disease? So it's a group of heterogeneous disorders that are unified by presence of at least one beta globin gene that is affected by sickle cell mutation. So this definition is kind of like high, so we'll simplify it. So if you want to simplify the definition, that would be it's an inherited disorder of the red blood cell which affect the hemoglobin, and so that hemoglobin is, because of that sickle cell mutation, it polymerizes under certain conditions like low oxygen tension, low pH, or increased concentration of the sickle cell hemoglobin in the RBC that leads to polymerization of the hemoglobin, in which the red blood cell that's normally like well circular, which becomes like a sickle, and its shape is deformed. So that doesn't passes well through the blood vessel easily, and it obstructs a blood vessel. So, and that leads to cascade, which causes hypoxia and acute as well as chronic tissue damage. So genetics, it's autosomal recessive disease, and in which there is a single nucleotide mutation on chromosome 11, which leads in the beta globin gene on the chromosome 11. That results in substitution of the valine. Valine substitutes the glutamic acid on the 6th position on the beta globin chain. So that's the main reason that the the hemoglobin in the RBC can polymerize and the cell becomes the sickle shape. So how common is the sickle cell? So sickle cell, it's more common in the person with the African, Mediterranean, Middle Eastern, Indian ancestry, and also in person from the some of the parts of the Caribbean and Central and South America. It's more common in that area. So it's also in US, it's about 1 in 2,000 to 2,500 children, and in African American, it's about 1 in 500 children. And so this is the most common condition that is identified in the newborn screening. So it's quite prevalent. If you consider the how many conditions we test in the newborn screening, this is one of the most common conditions. Okay, so it has some protective effect against the malaria, and so it's in the heterozygous state, okay, and it protects against the falciparum malaria. So there's a survival advantage in some part of the world like sub-Saharan Africa and Middle East and India, because there is a high prevalence of malaria in all these regions, and it's kind of like they have protective effect and malaria is also severe in these areas. So that also is a severe disease. So why it is important and why it was added in the newborn screening? So it was recommended in 1987 to be added in the newborn screening, but it was not implemented in all 50 states until 2006. So it's very important because not all the countries in the world does the newborn screening. So it's very fortunate that we do here in US. And so newborn screening will help us to identify those who have this disease. If we identify them early and educate the parents, and if they are taken care well by the comprehensive center, then it markedly reduces the mortality and morbidity of the sickle cell. And other thing, if we start prophylactic penicillin early in the life, it also decreases the invasive pneumococcal disease. Okay, so next is the interpretation of the newborn screen. So in the newborn screen, they will mention like what different hemoglobin they have. So the highest concentration the hemoglobin, they'll mention it first. So like all the has F the first, that means they have a highest concentration of the fetal hemoglobin. Whatever the next quantity is, they'll mention it next. So the first one is FA, so that's the normal, the fetal and adult hemoglobin. Okay. Then FAS, so that's the sickle cell triad. If they have a sickle cell, it will be no adult hemoglobin. So that way we can say it's FS is the sickle cell, or it can be the sickle cell beta 0. Sickle cell beta 0 is kind of like they have sickle cell mutation as well as the beta thalassemia mutation, but they don't have any. They don't produce any the beta globin chain at all. And the other one is the persistent hereditary fetal hemoglobin. That's also can be combined with the sickle cell. And then we have a hemoglobin S disease, sickle cell beta negative, and the sickle cell trait with alpha thalassemia. And F is beta thalassemia major. Okay, so this slide is very important. So there's a sickle cell anemia, sickle cell disease, and carrier stat. So when I was talking to Dr. Kloffenstein, she told me to put the importance on this slide, because when we write in the chart or in any patient like a documentation, it's very important to be specific whether they have a sickle cell anemia or they are carrier or they have a sickle cell disease. So they are slightly different. So sickle cell anemia includes only two things. It's either HBSS disease or sickle cell beta 0 thalassemia. So that does not include the hemoglobin C disease or heterozygous, like a hemoglobin sickle cell D or beta thalassemia plus. And the carrier state is not included in either of them. So carrier is not included in sickle cell anemia or in the sickle cell disease. Okay, so this is our main focus for the primary care physician. So, and because the children with the sickle cell, they have very high risk of developing multi-system acute or chronic problems. And some of the signs can be very early onset, and if we can detect those signs and symptoms or very early, we can address them and we can reduce the mortality. So there are a lot of things, like all the system-wise. The only thing is that we may not be directly doing all these things, but when we see the patient with the sickle cell in the clinic, you have to make sure that they are getting all these services. Some of them we may have to refer them, like for the eye exam or those kind of thing, but some of them they may be getting from the hematology office, or if they are going to sickle cell center, they may be doing those things. We just have to make sure that when the patient comes to our office that they are getting all these things to be done, so that we don't miss certain thing and find out at the later stage of the disease. So these are the things that we'll talk in the health maintenance, which is prophylactic penicillin, vaccination, stroke screening, cognitive impairment, retinopathy, pulmonary problems, and cardiovascular, renal, bedwetting, contraception, and reproduction. This image is just to show, like, it affects from head to toe. It affects the majority of the system. We'll come through this image again later on. So if any patient with the sickle cell, it's the best for them to manage or overseen by the comprehensive sickle cell center. If there is no sickle cell comprehensive center around the area, then their care should be under consultation with the pediatric hematology oncology. And these children should be seen at least every 6 months or every 12 months, either at the center or by the pediatric hematologist. Okay, so first part in the health maintenance, invasive pneumococcal infection. So the children with the sickle cell disease, especially the sickle cell anemia, which includes HBSS and sickle cell beta, there are high risk for the invasive pneumococcal infection because their splenic function is affected very early. They may have absent splenic function early in their first year of life. And so that's why they are very high risk for the pneumococcal septicemia as well as meningitis. And people with the HB sickle cell C disease and sickle cell beta thalassemia, they don't have like significantly affected function early in their life. Usually they will have the splenic function will be affected, but usually it's later in their life. And so they don't get early invasive pneumococcal infection. So there are 3 steps that we should do for the prevention of the pneumococcal infection. First is the education, second prophylactic penicillin, and vaccination. Vaccination against the pneumococcal and other encapsulated organism. So education. So all the family member, patient, and who else is going to take care of that baby, like if they go to daycare or somewhere else, all the people should know that if this child has a fever, especially the high fever, they need to be seen immediately. It's the emergency for them. So, and typically, we define the fever as 100.4, but when the fever is 1 or 1.3 or higher, it's very it's high risk for them at that point that they may have a pneumococcal infection. The second thing is prophylactic penicillin. So they should get oral penicillin, 125 milligram for those who are less than 3 years old, and 250 milligram those who are more than 3 years old, twice a day. And this is for HBSS. So those with the HBSS disease, this is for them. And we should consider discontinuing of the prophylactic penicillin at the age of 5 if they had, unless they had a splenectomy or pneumococcal infection. And before you discontinue penicillin, we have to make sure that they had all their vaccines that they need, they had all that done. If they haven't that vaccine, we may consider continuing if they haven't finished all their vaccines. The next thing about the prophylactic penicillin, so there are many centers that all the people does penicillin about all the children, like even with the sickle cell C disease and beta thalassemia plus. But the newer recommendation said you can consider withholding this prophylactic penicillin, but it varies, and it depends on the center. Vaccination, pneumococcal vaccine, so PCV13, so they should initially get 4-dose series, which includes 2 month, 4 month, 6 month, and 4th dose at 12 to 15 month. And then in addition to that, they should also get the pneumococcal polysaccharide vaccine, which is 23-valent vaccine. And so they should get first dose at 2 years and second dose at 5 years. So it's only 2 doses of polysaccharide vaccine, one at 2 years and one at 5 years. So the PCV13 vaccine is the newer vaccine, and we recently, in last couple of years, we started giving that. So some of the older children, you may see that they had a PCV7 vaccine before. So for those children, you want to give them one PCV13 and then give them a polysaccharide vaccine. Let's say if they did not have any vaccination, like neither PCV13 nor polysaccharide vaccine, then you want to give them 1 dose of PCV13 and then 1 dose of polysaccharide, that is 23-valent vaccine 8 weeks after the PCV13. And that's for the age 6 through 18. Any confusion? This part is kind of little bit confusion. So.
Well, it's not. You mean all of them should be given, correct?
Yeah.
Yeah.
Okay. And the second vaccine that they need is meningococcal vaccine. So there are 3 types of the meningococcal vaccines that are in the market. And so you can see the top 3. These are the vaccines that's available in the market. And so in this one, there's a specific thing. So when they get a primary series at 2, 4, 6, and at 12 months of age, we should use either meningococcal ACWY or Hib MenCY. We cannot use the third one, that is meningococcal ACWY-D, because that is not approved under the 9 months of age. So for primary series, we should use only the first 2 vaccines. And they need booster dose at 3 years and then every 5 years. In the pneumococcal, it was booster dose at 2 years and then 1 dose at 5 years. But in meningococcal, they need booster at 3 years and then every 5 years they need revaccination. And let's say if you see the infant of 9 months through 23 months, if they did not receive any meningococcal vaccine, then you can use the third one. And for that, then they don't have to get all 4 doses. They can have only 2 doses, and you can use either one. Any question about this one? Okay. All right. So stroke screening, we'll talk more. Stroke is one of the common and devastating complications for the sickle cell. So we'll talk this one when we go into the complication part, because I combine both screening as well as complication in the same time. So we'll talk about during the complication. The cognitive impairment. So all the children with the sickle cell disease, they have a higher rates of neuropsychological dysfunction, and some of the risk is for the silent stroke, acute stroke, and even if they did not have a stroke, they are still at a higher risk for the neuropsychological dysfunction, which includes low intelligence, attention problem, memory, language, difficulty at school. So all the children, if you see they are not making good grades and they have attention problem, language problem, they should be evaluated, and you should do like a neuropsychological testing and all other testing that they need. And they should also get some intervention or help at the school so that they can do better in the school. Next we'll go through is the retinopathy screening. So children with the sickle cell, they have a high risk of retinal disease because of the vaso-occlusive crisis, as well as the ischemia in the retinal area. And especially it's higher in the person with the sickle cell C disease. And when the initial phase, the reason that we need to screen them is that if the progress is to progressive or proliferative retinopathy, that's very bad because they can lose their vision if they have a progressive retinopathy. And in the studies, it's been reported it's about 4 to 5% prevalent. So screening wise, we have to make sure that we refer them at the age of 10 for the dilated eye examination, and if the eye exam is normal at that point, they should be re-examined at every 1 to 2 years. And if say that eye exam is abnormal, then we should refer them to retinal specialist in case if they need surgery, and there are certain things that they can do like laser surgery and some, so that may be helpful if they have like a proliferative retinopathy. So next section is the pulmonary. So again, all the children with the sickle cell, they are high risk of having pulmonary conditions, and with that condition, let's say if the person has asthma without sickle cell disease and person with the asthma and sickle cell disease, that person is a high risk of getting sick, as well as they also have a high morbidity and mortality. So we should screen them at each well-child check visit for any pulmonary problems like asthma, COPD. Actually, COPD is the old age, but that's for the adult. Any other like sleep apnea. So we should ask them and look for them. If they have any symptoms that is concerning for pulmonary problems, then we should do pulmonary function test and other tests like sleep study or according to the problem. But if they don't have any symptoms, they don't need to be screened. There was previously, it used to be done, all the children with the sickle cell used to get pulmonary function test every year. So they don't need each year unless they have symptoms. So asthma and sickle cell, they don't go well. when person has asthma and sickle cell disease, they are at high risk of getting acute chest syndrome, vaso-occlusive crisis, and there is also some report that shows that they have lower lifespan. So any children with the asthma or history that is suggestive of the asthma, we should refer them to the pulmonologist for the management, regardless of their severity. Even if they have like mild to moderate disease, it's better been managed by the pulmonologist. Pulmonary hypertension, this is more like an adult problem, but we can still see in the late adolescent phase. So that's why I put it here. So because of chronic hemolysis, they may have changes in the blood vessel, and which causes thickening in the arterial walls, and which may result in the pulmonary artery hypertension. And symptoms for them, they may complain like exertional dyspnea, fatigue, limb edema, decreased appetite, or sometimes even syncopal episodes. So any patient, if they complain this kind of symptoms, they should have an echo done, and we should refer them to cardiologist for the evaluation. The other thing about them is that if they have if you do the echocardiogram during they have vaso-occlusive crisis, it will be probably abnormal. So ideally it should be done when they are not sick.
Don't get many here. Where are they?
Yeah. Okay. The next thing in the cardiovascular is the hypertension. So there is no special recommendation for the high blood pressure as we do for the other children. Like every well child visit, they should have a blood pressure to be recorded, and if they have a high blood pressure, we should manage as like we do for the other children according to the NHLBI guideline. So there is no different for them. And previously there was a debate about whether they need regular EKG screening or not, but the 2013 guideline says they don't need routine EKG unless they have some symptoms that we need for. Renal, so for them, because of sickle cell, they develops the nephropathy, and that's one of the major complication with the renal, and that affects their tubular function as well as the medullary function, and that results in the initial phase they may have like a defect in the concentrating the urine as well as acidification. Later on they'll develop microalbuminuria and proteinuria, and they may go into the renal failure. And some of the studies has reported the incidence of the chronic renal failure between 4 and 20% when they have a progressive proteinuria and azotemia. And so screening for the renal disease, all the children with the sickle cell, they should have a urine analysis to look for the proteinuria from the age 10 onwards. And if it is negative, we should screen them annually. And also, if it is positive, either we can directly refer to Dr. Wattard, nephrologist, or we can do like morning voiding urine and look for the albumin creatinine ratio. And if it is abnormal, then refer it. Bedwetting, again same. Reason for that is again same, the sickle cell nephropathy and inability to concentrate urine very well. So that's why they are high risk compared to other children without sickle cell disease for the bedwetting. So management wise, as we all know, no punishment for that, and treatment is same as the other children. And it's very important that we limit their intake in the afternoon, but make sure that they get their daily fluid in the early morning and the noon and afternoon period, because if they get dehydrated, again they are at risk for the vaso-occlusive crisis. So we have to make sure that they're hydrated, as well as we limit their intake in the evening time. And all other bed alarm and all other stuff works well with them too. Contraception part for the adolescent. So the progesterone-only contraception, which includes pills, injection, and implant, levonorgestrel, IUDs, and the barrier method, we can use same as the other adolescent. There is no restriction about sickle cell patient. And progesterone-only contraceptive pills or the implant, they have additional benefit too. It may decrease their crisis, like their number of vaso-occlusive crises. It may decreases. It does not increase the risk for the thrombosis. Whereas combined contraceptive pills, that increases the risk for the thrombosis, and the stroke patient, they are also, combined pills is contraindicated for those who have stroke. So sickle cell, they are high risk for the stroke, and about 11% will have a stroke, silent or the acute stroke by the age of 20. So that's why we have to be very cautious or not to use the combined pills unless you are sure. Talk to hematologist as well as the OB or someone before you prescribe them a combined. Reproductive, we usually don't deal much about them, but we have to make sure that adolescent patient, when you see them, if they have a partner and they are going to marry, we have to make sure that the partner has been screened for the hemoglobinopathies, because if they're married to someone who is a carrier, then there is a high risk for their kid to be having sickle cell anemia. And they should also, if the both partners are positive, we should refer them to genetic counseling. Okay, we'll go to the next, the complication part. So as we saw this picture, similar picture earlier, there were a lot of complications and problem with the major system. So we'll talk about this complication: acute vaso-occlusive crisis, fever, dactylitis, acute chest syndrome, priapism, acute splenic sequestration, aplastic crisis, and stroke. So because of this complication, their lifespan is also decade or 2 decades lesser than those who don't have a sickle cell. So acute vaso-occlusive crisis, usually they manifest as a severe pain, which is common in the chest, extremity, or back, and usually it's a sudden onset, but sometimes it can be a gradual onset, and it's one of the most common complication of the sickle cell, and it can last from hours to days. So it's very kind of like painful condition, and it's, unless you give them a significant amount of the pain medication, it's very stressful for them. And the common trigger are the stress, cold exposure, dehydration, and infection. There's no specific test that you can say, yeah, this is the vaso-occlusive crisis, but you have to rule out the other condition. When patient comes in with the pain, you have to rule out the other condition and then treat the pain. So you have to rule out infection, osteomyelitis, abdominal problem, bone infarction, all other things, and go from there. So for them, it's pain is emergency, and major center have a pain protocol for them. So as soon as they enter with the pain, they have like a 30-minute or 60-minute window that they have to initiate that pain protocol. And while we treat the pain, we should also look for the other causes of the pain. And in the next slide, we'll talk about like what are the things we should look for. So, we should be more liberal than the other patient about giving them a pain medication. And they also need the frequently reassessment of their pain, like every 15 to 30 minutes. We have to reassess their pain score and see if their pain is coming down or not. Mild to moderate pain, we can start with the NSAIDs, but we have to make sure that they don't have a renal failure or gastritis or other contraindication. Moderate to severe pain, we can directly start with the IV opioids. Opioids, meperidine is the only one that ideally we should not use unless that's the only choice we have, because it has a shorter duration of the half-life, as well as it produces the toxic metabolite that can cause like a tremor and other neurological problem in the children. So that's why meperidine, we should try to avoid that. And when patient comes in the pain, sometimes they get lot of fluid, and that may get overloaded with the fluid, and which is also the risk for the acute chest syndrome. So when children get hospitalized for the vaso-occlusive crisis, they may get acute chest syndrome during the hospitalization. So there are certain things we should do so that they don't get the acute chest syndrome during the hospitalization. So like encouraged early ambulation and incentive spirometry. In addition to medication, we should use non-pharmacological approaches for the pain medication to treat their pain, like local heat, distraction. We talked about hydration part, and also reassess their pain scale, because excessive sedation also not good for them. And also we have to monitor their saturation very well, because if their sats are dropping, that's one of the early indications that they are also going into acute chest syndrome. And we should maintain their oxygen above 95%. And if they are still not responding to pain and still deteriorating, look for the other causes. And they may be going into multi-system organ failure. Okay, fever, again, as like a pain, fever is emergency, and typically the high fever of 38.3 or above. Even though we started doing widespread immunization against the pneumococcal, there is still possible that they are not immunized, because there are some parents who don't believe in the immunization or they don't like the immunization. So there's still risk that they have a invasive pneumococcal infection. And there's also risk of penicillin resistance. So that's why we have to be more urgent about them. When they come with the fever, we should do the CBC, retic count, blood culture, and if you suspect UTI, then should also do urine analysis. So this condition can be managed as an outpatient if they don't have this high risk factor, like their WBC is not more than 30,000 or less than 5,000, they are not ill appearing, the fever is not more than 40 centigrade, and they have a reliable follow-up, and they live close by to the hospital, so that if child deteriorates, they're coming to hospital soon, and reliable parents. Otherwise, if they have any of these high-risk features, then they should be admitted in the hospital, and they should get the antibiotic that covers the pneumococcus. Generally, start with the cephalosporin. Okay, so these are the conditions that when they come with the pain, and the fever, we should make sure that it's not only vaso-occlusive crisis. Sometimes we focus too much on the pain that we forget about to rule out the other causes. Like if they have pain with the fever, they are still risk for the infection. If they come with the fever and shortness of breath, cough, and other pulmonary symptoms, they may have a acute chest syndrome. And if they have a fever with the bony pain, they may have like a osteomyelitis or other bone problem. Okay, so we'll go to dactylitis, which is hand-foot syndrome. So this is also a type of vaso-occlusive crisis, and it especially occur in the infant and young children, and especially in the HPSS type of disease. And usually the vaso-occlusion occurs in the metacarpal and the metatarsal, and they present with the swelling of the hand and feet, and they're very tender. It occurs about 25% of the infant by the 1 year of age, and about 40% by 2 years of age. So their management is kind of same as the other vaso-occlusive crisis, like making sure they're getting enough pain medication and adequate hydration. And here is a picture. If you see the right hand of this kid, it looks more swollen and puffier than the left one. So usually they have like sometimes they may have like a quite erythema and all other features too. Next is acute chest syndrome. So if you see the patient with the chest syndrome, they look kind of similar to like they have a pneumonia. They will have a similar findings on the clinical exam as well as X-ray. And as we discussed earlier, if patient was hospitalized, they may get during the hospitalization. And common causes for them is infection and mycoplasma and chlamydia pneumonia are these are the two that considers about the 50% of the infectious cause. And when we suspect the acute chest syndrome, we should do like a chest X-ray, monitor their oxygen saturation, also do the CBC, retic count, and the blood culture, and start antibiotic immediately. And for them, we should also include the, in addition to cephalosporin, we should include macrolide antibiotic, because if you see the 30% of the patient will have infection, and common cause is mycoplasma as well as chlamydia. So we should also include the oral macrolides. They may need a blood transfusion if they are dropping their the hemoglobin with that, and sometimes if it is rapidly progressing, they may not tolerate the full blood transfusion. So at that point, they may need exchange transfusion. And once they start recovering, we should consider starting incentive spirometry. And here is a chest X-ray, which is kind of looks typical, similar to the pneumonia. So these are the things that you will see in the chest X-ray. The next is the stroke. So in the children, usually we'll see the ischemic type of the stroke, but in the adult, we'll see more like a hemorrhagic stroke. And it's about 10% in the before they turn 20, 10% of them will have a stroke. And the peak incidence is at 4 to 8 years of age. And typically they present with the one side weakness, facial droop, dysphagia, dysarthria, and sometimes they may present with the seizure and coma. So they need urgently CT, and they may need MRI and MRA. Even sometimes if they are present very early in the stroke, they may not have a CT finding. So even though they don't have a CT finding, they should be treated as a stroke if they have weakness and typical symptoms of the stroke. And they need exchange transfusion, and they should be put on the chronic transfusion protocol. Because chronic transfusion protocol, it will reduce the risk of the second stroke. And even patient with those who are on the chronic transfusion, they are still at the high risk of getting stroke, and about 20% of them will get a stroke, the second stroke. So the screening for the stroke is transcranial Doppler, which is usually done in the comprehensive sickle cell center. So what they do is kind of similar to that the Doppler ultrasound. They'll put the probe on the medial side of the head, and they will measure the flow in the middle cerebral artery. And if the flow is higher, is the high risk. So if the flow is between 170 to 199, that's called the conditional, and more than 200 is the elevated flow. So those who have elevated blood flow, they should be referred for the chronic transfusion, even if they don't have a stroke, because that will cut down their stroke risk significantly.
Nilesh, one quick question. When you talk about these strokes and transfusion, you're referring to sickle cell?
Yes.
You're referring to any stroke of any of the other?
No, about the sickle cell.
That's it.
Yes. And especially in the sickle cell anemia patient. There was some debate in the past about whether to do the transcranial Doppler for the other types of the sickle cell and not. So it's only recommended for the sickle cell anemia and not for the others. And they also don't need regular CT or MRI if they don't have any symptoms. Okay, next is priapism. So this is a prolonged painful erection of the penis with typical onset early in the morning hours. And so there are two types in this. There is a stuttering as well as prolonged episode. The stuttering is the self-limited episode and usually occurs in the cluster, while the prolonged episode usually lasts more than 4 hours. And usually occurs in the young children about 3 years of age, and for them we need to have, when we see this patient, they should have aggressive pain management as well as some pharmacological medication that we can treat like pseudoephedrine or the ethylephrine. And if they are not resolving as we expect, we should immediately refer them to the urologist, because if we don't treat them aggressively, they can become permanently erectile dysfunction. So the urologist, what they will do is they will do irrigation and the aspiration of the cavernosa. That will reduce their blood with the sickle cell. The next complication is splenic sequestration. So in this one, the child usually presents with the sudden enlargement of the spleen, and their hemoglobin will be dropped from their baseline. So usually occurs at 5 years of age, and below the 5 year of age, and typically you will see more around the 2 year of age. And but in the patient with the sickle cell, the hemoglobin C disease, they will have more at the older age, like at the age of 10 or older. And usually it's the clinical diagnosis, don't need to do any other testing. But if you suspect that their hemoglobin is dropping and you don't feel their spleen, you may consider doing ultrasound, and that may be helpful. And they will have other typical symptoms of the anemia. So parents with the children with the sickle cell, they should all be educated about the feeling their spleen every day. So so that we can detect the acute splenic sequestration early. And routinely, all the major center will teach all the parents like how to feel their spleen. And for the treatment, they need the blood transfusion, but we should be very careful transfusing them. We should not take their hemoglobin to like a 13 or 14, because if you take them to that level, they'll again have a problem. And other thing is the auto transfusion, because when you treat that crisis with the transfusion, in 2 or 3 days, their spleen will get smaller, so it will eject all the bloods that was in the spleen. So they will have a more problem. And if they keep having the splenic sequestration, then they need a splenectomy after the second or the third one. Okay, chronic cholelithiasis or the gallstone, as we know, like it's a hemolytic anemia, so it will increase the bilirubin production and it will precipitate in the gallbladder and causes the gallstone. And symptoms will be typical of the right upper quadrant pain, jaundice, vomiting, and we should refer them to the surgeon and they will decide if they need surgery or not. And if they have symptomatic stone or the obstructing stone, and then they'll do the surgery. But if patient has asymptomatic gallstone, they don't need the surgery right away. Aplastic crisis. So this is PARO-B19 infection. So usually if the other kids get the PARO-B19 infection, they may not be affected that severely, because the normal RBC lifespan is about 120 days. And when the PARO-B19 infection occurs, it will stop the bone marrow, RBC production in the bone marrow for about for about a week or two. So because the normal children have a longer lifespan, they will not be affected. But the sickle cell RBC, they have shorter lifespan. So that's why their bone marrow will shut down and they will have a profound anemia and all other symptoms of the anemia, like decreased activity, poor feeding. And at that point, we should evaluate for them with the CBC, and you will see the severe anemia as well as reticulocytopenia, and management for them is also the transfusion. The next is the avascular necrosis. So these children they are at the high risk of getting avascular necrosis, because when they have like a minor sickle cell crisis in the particular bone area, especially the shoulder and the hip joint, their blood supply gets interrupted, and they'll present with the hip pain, shoulder pain, or sometimes even the knee pain. So they need X-ray or MRI. X-ray, they may not show in the early stage, so if you are suspicious for that, just get an MRI. And referral to orthopedic and pain management and physical therapy. Adverse fetal outcome. So the pregnancy is a high risk, any mother with a sickle cell, and the baby may be IGR, or they may have a preterm delivery or the stillbirth. And frequently the patient with the sickle cell exposes to so many transfusion, so the infant or the baby may have alloimmunization, and they may have a significant hemolytic anemia and or the mortality. And other thing is that mom maybe get treated with the opioid during the pregnancy, so baby may have withdrawal symptoms too. So the treatment part, we'll quickly talk about that. So hydroxyurea, so this is initially was developed as a chemo drug, but then later on it was found to, it increases the hemoglobin, fetal hemoglobin expression, And so at that point, it was started using for the sickle cell patient, and it significantly decreases the vaso-occlusive crisis, acute chest syndrome, and the ductilitis in the patient who are getting hydroxyurea. We should offer all the children with the age 9 and above the hydroxyurea, and they have a minimal toxicity like a myelosuppression, so we should monitor their blood count while they are on the hydroxyurea. The transfusion therapy will not go into all the details, but they may need, as we talked earlier, during the splenic sequestration or during the acute chest syndrome. The chronic transfusion therapy, as we talked earlier, if they have a stroke or if they have a transcranial Doppler that is showing that their blood flow velocity is higher, they should be put on the chronic transfusion protocol. And the risk of the chronic transfusion is the iron overload and getting the other infection from the multiple transfusion. So one way to decrease the risk of the alloimmunization is to ask the blood bank for the specific antigen type matched blood. So that will cut down the risk of the alloimmunization, as well as we should monitor their liver function, serum ferritin level, and they should be also screened for the hepatitis B, HIV, and hepatitis C annually. And iron overload screening, which is usually done by the higher center. And if they have iron overload that is shown, they should be treated with the chelation therapy. And nowadays, most of the center uses Defirox, then the other one. And the curative treatment for the sickle cell is the hematopoietic bone marrow transplant, and this is the only cure that is available, but it's not very widely available because it has some limitations. It has to be right now they do bone marrow transplant only from the matched sibling, and doing only for those who have a severe disease and they have a recurrent chest syndrome or the vaso-occlusive crisis. And there's also a significant risk with the bone marrow of failure versus graft versus host disease. So right now it has a limited use. The therapy that is still under the research or under investigation is the gene therapy, other drugs that increase the fetal hemoglobin expression, and the bone marrow transplant from the unrelated donor. The prognosis still, even with the advancement in the science and widespread immunization, use of hydroxyurea, still their life expectancy is quite 1 or 2 decades shorter than the normal people, those who don't have a sickle cell. And but with doing that, children's life expectancy has improved significantly. 98% of the children survives at least through the 18. And this is and these are some of the references that I used. Any question about anything?
Educate me. How do you do the neonatal screening?
So neonatal screening, they'll do the newborn screening.
Yes.
And once you get the newborn screening result,
Do it.
so
How?
the heel prick, and they'll collect the blood in the card and then send it to state.
Do you know what they do there? Hemoglobin electrophoresis? What is it?
No, they don't do electrophoresis.
Okay.
So once you get the result back from the state screen that is positive, then you should do confirmatory testing with the electrophoresis.
The only other thing which when we were talking about this talk, I forgot to mention was these patients are high-risk surgical patients. So if they're going to have surgery, they're going to have their appendix out, their gallbladder out. Ideally, they need to be transfused for once a week, every other week for a couple of weeks to get their percent of hemoglobin S down. They're at high risk for acute chest syndrome. So don't just send a sickle cell patient to ENT or to see Dr. Taylor without calling us and letting us know the kid needs surgery, so we can make appropriate arrangements and make it safe for them.
So how is acute?
If it's acute, you can give them a transfusion, a straight transfusion, which will sort of bring down the percentage, and then we just really help them monitor them closely. Yeah, if you have an appendix, you can't wait a month. But you know, if it's your gallbladder, or your tonsils, you probably can wait.
So what's the favorite blood pressure medicine that you would use for him?
They,
Any in particular?
they did not say. They said you manage as the other kids. There is no specific medication that works better than the other.
It seems to me ACE inhibitor is probably the best if you want to think about reducing microalbuminuria and others.
Yeah.
Nilesh, this is a wonderful, extensive review. Thank you very much.
Thank you.
It's great.